So, okay. So, thank you very much. I'm going to be talking to you about the current medical and surgical innovations in glaucoma management. And we've already heard from Dr. Nijam the fallout from glaucoma management, but I have some pearls that might help. The prevalence of glaucoma is the third leading cause of global blindness and after uncorrected refractive error and cataracts, and it's a progressive, silent retinal ganglion cell disease. The traditional medical therapy for lowering pressure has been unchanged for quite a number of years. And for the most part, it gives about 20 to 40% a reduction in pressure, and it's doing so by many mechanisms. So Dr. Nijam did go ahead and give us an overview of this. However, of note, the group that was added back in '07, the prostaglandin analogs that decreased uveal scleral outflow had the largest pressure reduction aside from the carbonic anhydrase inhibitors. The rest of the medications that we've had for a very, very long time were mostly in the category of decreasing aqueous production, except for pilocarpine, which was the only direct agonist that increased outflow. And then in come the novel therapies. And these therapies have really been a game changer for refractory care and glaucoma patients that might not be amenable to surgical treatment, might be a little too old or for whatever reason. And that class of those class of agents are a novel class of agents, first ones in 20 years to be introduced. And we have 3 of them that are currently in use in the United States. And the one that's most effective, of course, is the fixed combination Rho kinase inhibitor, the tarsadil and latanoprost together. And as you can see, all 4 categories in terms of the mechanism of action are active in this particular drug, the fixed combination. The only sad part, of course, as Dr. Nijam mentioned, is that it wreaks havoc on the ocular surface. The ocular hyperemia is significant in almost 60% of patients, and it also is associated with cornea vesiculata and conjunctival hyperemia. This novel drug, this long-acting implant, is the next horizon, so to speak, and it has a great safety record and IOP reduction of about 30 to 33%. So I'm going to show you a video of the implantation of Durista.
Implantation of hematocross implant 10 micrograms in the left eye of this lady who had an implantation done in her right eye 2 weeks before. After laying out the necessary supplies, the lid spectrum was put in their left eye after it had been prepared with betadine. The sterile applicator was removed from the box, and after inspection, the needle was used to pierce the supratemporal peripheral cornea, and the actuator button was pressed, releasing the drug into the anterior chamber. A sterile Q-tip was applied to the supratemporal needle track, and soon after, there was no view of the Durista implant in the anterior chamber as it settled into the inferior angle. The lid spectrum was subsequently removed from the eye, and a drop of antibiotic instilled in the eye. The patient remained in the upright sitting position for 15 to 20 minutes and then was released to go home.
Durista has been a wonderful addition to my armamentarium, and I use it in patients that can't tolerate medication, particularly those that either have allergies to medications and a number of different reasons, memory loss, etc. So it's a great addition. Hopefully with the new studies that are going to indicate in terms of how long this drug can last. Right now in the US, it's only allowed to be used once a year, and we may be able to customize that in the future.
Video shows
Novel strategies are on the horizon that are non-IOP, that are IOP independent, but we don't have time for that at this time. So we'll move on to surgical innovations. And we have MIGS, minimally invasive glaucoma surgeries, and LIGS, less invasive glaucoma surgeries. And these modalities are new modalities that offer us an alternative to trabs and tubes. And so this internal procedures, for the most part, have great safety profiles, have the use of the gonioscope. So that takes a little bit of getting used to. And turning the patient's head, positioning the patient is something that needs to be worked on when you're trying to learn this modality. The targets are the conventional outflow and the uveal scleral outflow. The one drug that was uveal scleral outflow related is no longer. CyPass was recalled. The LIGs are subconjunctival route, the Zen, and of course P3 laser, which is the newest modality for laser treatment of the ciliary body. So again, these are the different mechanisms and types of MIGs and LIGs that are available. The iStent Supra and the InFocus are not yet available. And ECP, the iStent inject and the Hydrus have to be combined with cataract surgery in the US. So these are the images of the different types of devices that we have, in case you are not familiar. And in terms of staging, with my patients, I really customize what their needs are. The MIGs I use in mild and moderate cases. I do not tend to use them in severe cases, but I do use LIGs in severe glaucoma. And I also use the P3 laser in combination with a lot of these as well. So here's some, this is a video. This patient had a previous cataract surgery as well as a previous glaucoma surgery. And this is an Omni surgical system. It viscodilates as well as does the gonioscopy. So it's really whatever you need or want for the patient. In this case, I will be unroofing the inferior portion in order to perform the goniotomy.
What you want, if you want to do the full 180 degrees, do an entire 360 degree goniotomy, or if you want to viscodilate one half. And here you can see that I'm unroofing the canal as I'm retracting the catheter so that I'm performing goniotomy.
So in the interest of time, we'll move on. The Zen Ab Interno was the original way of implanting this device. I am demonstrating a video from Dr. Bedrud, and you'll see that there are certain techniques that can be used to mark the conjunctiva in order to be able to place the Zen in a proper position. The Vera hook is then used to apply counter traction so that you can deploy the Zen, and if you mark the tip, you can see it in the subconjunctival space to make sure that you don't get caught up in Tenon's capsule, and that is very important because the primary reason for scar tissue formation in this particular procedure is scarring at the level of tenons. And you want to test to make sure that you have a mobile Zen. So the LIGs can be used in refractory cases, as I said before. And in this particular patient, I had implanted a Zen that was successful on the right. On the left, I had trouble with the Zen such that it was bent. I went back and did an external Zen implantation. You have to be really careful when you're implanting not to have it go too far, because the loader can sometimes overshoot. So you want to have the delivery be subconjunctival and not get caught up in tenons. You test and close your conj with 9.0 Vicryl in a running locking fashion.
External Zen implant video.
So this patient had 2 successful Zens placed, and the P3 I use for anyone that needs additional lowering, especially if they've already had, as this patient, other procedures like a micro express. So in summary, MIGs and LIGs can be used to customize and personalize the individual needs that your patient need to achieve your patient's target pressure. And it does not preclude traditional surgical options later on. So thank you very much for this opportunity to speak.
Thank you, Dr. Pappas.